Thank you. So it's really quite a fascinating day listening to the distant past and the more recent past, and realizing how our specialty is continually in evolution. And we know there's been big changes in perinatal mortality. We know that there's been changes in obstetric care, but actually even I've been in obstetrics for 21 years, and even in that time, things have changed. Theatre lists, when I started out in obstetrics, there was a lot of tubal ligation and there was a lot of hysterectomy. And now with the Marina coil, that has taken many of those patients out of the hospital entirely, not just out of the operating theatre. So it is a specialty continually in evolution, and I am really fascinated to see what the next 20 years will bring. And Sorcha and I are both going to speak about the current and about the future, and how things may evolve and what our take is on it. We'll be fascinated to have input from the audience afterwards as well, because the nice thing about today is there's no wrong answers. It's all about a discussion and seeing what way things are going to go. So this is the paradigm in which we currently work. There is no newspaper that you open up any day of the week that doesn't have something to do with obstetrics and gynaecology. And unfortunately, unless you watch the Rotunda programme on TV, most of what you're seeing is tragically negative. And that is a difficult place for people to, deliver care, but also to have pride in the work they do. And for those of us who are consultants, to bring people along behind us and to deliver training. Because everybody has a comment on obstetrics and gynaecology and how things could be done and should be done, rather than necessarily how they are done. And I think it's important that we remember that context, and always when we are working with our trainees, that we realise this is what they are seeing too. This is what they're getting when they go home at the weekends, from their neighbours and potentially from their parents. So we do need to support people as they work in this paradigm. From the positive perspective, we do have the National Maternity Strategy, which has been adopted as government policy. And this is a 10-year strategy that is very broad in terms of what it suggests. There are 77 very far-reaching recommendations, all brought together to implement standard, consistent models for delivery of maternity services. It does acknowledge the service pressures. It identifies a need for 100 new consultant posts. We're 2 years into it now. As far as I know, the vast majority of consultant appointments continue to be replacement posts rather than new posts. It identifies midwifery understaffing, and in fairness, there's been a lot of work done on improving that, but still most units are still very challenged by midwifery staffing, because again, midwives are working in that context of constant clinician bashing. And it does acknowledge, this strategy acknowledges the government's commitment to relocating standalone maternity units. So there is, if you're to read the maternity strategy as an optimist, things are going to get a whole lot better. This is how we currently train people. We train obstetricians and gynaecologists through basic training, where they get their core competencies. The first 2 years of that are as a senior house officer, with at least 1 year being in a large urban unit. And in the course of these two years, they get their Part 1 MRCOG. They move to their third year as a basic specialist trainee, year 3. This is a 12-month appointment as a junior registrar, where they'll always work supported, and they'll always have a senior registrar on duty with them. And in the course of this, they will get their membership of the Royal College of Physicians in Ireland. Those 3 years are generally done within a single hub. So if somebody, for example, decides to come to the Rotunda hub, although the training programme is run by the Institute of Obstetricians and Gynaecologists, we divide it up into 5 hubs. So if someone's in the Rotunda hub, they'll do their first 2 years in the Rotunda, Cavan, and Drogheda and Beaumont, and then they'll move to year 3, where they can move to another hub if they wish, but they will generally stay within the same hub. So they'll stay with the people that they're used to, the environment they're used to, the staff and colleagues they're used to. Then there's higher specialist training, which is 5 years. In the course of that, most people will do 1 year or 2 years out of programme, either to gain a new clinical skill or indeed to do a period of research. People will usually, they'll already have their MRCPI, but they'll usually gain their membership of the College of Obstetricians and Gynaecologists. And after that, they'll receive specialist registration on the specialist division of the register. So it all looks very easy when you look at it like that. In our current training programme, we have 82 trainees. 64 of these are in clinical posts. The remainder then are doing their out-of-programme training. It's a national training programme, so the trainees will spend time in one of 13 or 14 maternity units, as well as some of the affiliated gynae units. The big challenge that we have faced in the last number of years is that the European Working Time Directive has reduced the number of hours that trainees are doing. This gives them a reduction in clinical exposure. We undertook this survey last year where we asked the trainees, how much do you enjoy working in the specialty? And on a scale of 1 to 10, 85% ranked their enjoyment of the specialty as being higher than 7 out of 10. So that's really, really positive. However, a third regret choosing it as a career, either on a monthly or more frequent basis. And a similar number think about leaving monthly or more frequently. A quarter actually think about leaving medicine more frequently than monthly. With that, half disclose experiencing abusive behaviour either from patients or their families more than once a month. And I'd be interested in hearing what Dr. Carr thinks about that in his day, and we can talk about that afterwards. You know, how frequently was he abused by patients or their family members? More than most agree that the European Working Time Directive has improved work-life balance, but a fifth would actually opt out if they could, due to concerns about competency acquisition, so that they're actually not getting the clinical exposure perhaps that they would like. So what can we do? I'm one of the specialty directors. What can we do to make things better, to keep people engaged, and to make it better, to fill that real negative vibe that's there as well? Well, we do need to continue to engage with and to value our trainees and to make them very much part of the solution, so that their training isn't just done to them, it's done with them because of them. One of the things we've done is we've tried to fill the experience and exposure and competence vacuum that some people have identified. So by doing things like simulation. So the picture on the left is of one of our simulation programs, our surgical simulation programs, where we obviously simulation can be done electronically on computers, but it can also be done by a simulated surgical environment. And that particular day is actually a cadaveric surgical module. So we're actually operating on cadavers, which is as close as you can get to the real thing. On the right, it's the obstetric simulation day. I think that was either breech extraction or management of shoulder dystocia. So that also means that people can hone their skills on something other than the patients on the labour ward. One of the discussions we have to have is, should we continue to strive to produce only a single product, that of a consultant obstetrician and gynaecologist? And other countries have split into obstetrics and gynaecology. Personally, I think we probably won't do that, but what we may do is bring in other things. So, for example, bring in a little bit more community gynaecology or gynaecology linked with primary care, particularly as we move in to provision of termination of pregnancy services, whether we will have people who have come through basic training and perhaps don't want to go through the full 5 years to become a all singing, all dancing obstetrician and gynaecologist. But I think we do have to look at other models. Some of you may be aware of associate specialists. In some of our large maternity hospitals, we have one outstanding associate specialist who works in colposcopy and the perineal clinic. And there are other people doing slightly variations on the theme as such. And I think we need to, who do that don't need to be thought of as outliers. They actually need to be thought of as part of the solution. And we do need to work collaboratively with our funders, with the government, Department of Health, HSE, and our patients, as well as colleagues in allied specialties, to look at service development. And more than ever, we need to support each other, because there are times when you can feel under siege, and it's important that we acknowledge that and that we look out for each other, and we don't just put the suit of armour on and keep on trucking. We ask our trainees quite frequently about things that we're going to do within the specialty and get their opinion on it. For example, many specialties allocate their higher specialist trainees for the full 3 or 4 years of the training programme. So the person knows they're going to be in Dublin, then Limerick, then Galway, then back to Dublin, for example. That's great, but the problem is if you decide to take some out of programme in the time when you're in Dublin, then maybe you'll miss your exposure to Dublin altogether. So it doesn't necessarily allow you to hone your skills to a particular area you're interested in, or it doesn't accommodate, for example, something like maternity leave. So we currently allocate our trainees for the first 2 years of their programme. Then we reassess and we allocate them then year on year thereafter. So some of our trainees had said, well, maybe we'd prefer to be allocated for 3 years. So instead of making a dictatorial decision, we actually surveyed them. And we found that more of them, almost 6 out of 10, preferred to be allocated for 2 years than 3 years. So that's what we continue to do. So this is what I mean. We don't just make decisions top down. We try and engage the trainees and hope it's their training, and hope that things get better for them and continue to get better for them. One of the things a group of us did almost 2 years ago was that we had traditionally been quite scared of work-related social media. Although we're all generally pretty opinionated as we sit around the dinner table, we weren't always the first to speak up on social media. Any of our speaking up was generally within conventional media circles. And obviously from the media perspective, there's often a focus on the negative. Negative news is more interesting. So what we did in December 2016 was we gave birth to We Are Delivering. And what this does is it highlights all aspects of obstetrics and gynaecology. We did put our head above the parapet and we didn't know exactly what was going to happen, but we have actually accrued a whole group of experts by knowledge. So that's doctors, nurses, midwives, pharmacists, chaplains. We have a load of experts by knowledge and a huge number of experts by experience who tweet on this hashtag. These are women, patients, family members who've been through the maternity services, and they have highlighted the good, the bad and the ugly of the services. And indeed, through We Are Delivering, we have created a bit of an impression. In the first week, we had 1,500 tweets, which created over 1 million impressions. And then we found, particularly as last year went on, that we became accidental advocates. And all of a sudden, people would say, I wonder what We Are Delivering think about a particular healthcare issue or a particular problem. At the bottom of the screen is the submission we did for the Institute of Obstetrics and Gynaecology prize art exhibition recently, where we did a word cloud of some of the words and themes that had come through this hashtag. So most of them are actually positive, whereas if you were to do an analysis of the Irish Times over the last year, most of the stuff about obstetrics would probably be negative. And it's interesting that while social media will often have a negative, will be thought of in a negative way, there are lots of positives from it. And I think this quote is good. If you haven't experienced social media, you might think it's just about sharing information, but it's not. It's about sharing who you are, what you do, what you're interested in, and that's what connects people. People connect with people. Technology is merely a way to facilitate that. And I think the other lectures over the course of today have shown the importance of individual people and the difference that they make. And actually, social media is kind of the same. But we do have to be very professional with our digital footprint. It's estimated, it's not going away, it's estimated that there'll be 3 billion social media users globally by 2020. So we have to maintain an online image and we have to maintain our good manners, because it does, through social media, our professional and our private lives are merging. There's no two ways about it. It's imperative for us as doctors to remember that the confidentiality of a patient is their right, and it is our duty to maintain that. So while a patient may tweet a picture of them in a clinic or whatever, that's their business. It's not, we have no right to tweet a picture of a patient in a clinical area without their permission. Brands, careers and reputations, just ask Sean Gallagher, can be damaged or enhanced by digital communication. And we need to accept that no matter how conservative our privacy settings are on social media, our privacy is not guaranteed. And you do put yourself out there a little bit by going on social media. So you do have to review your online presence regularly and make sure what you're tweeting is appropriate. I saw this the other day, actually, and I just thought I'd put it in. Many of you may have read this wonderful article by Colin Doherty, who is a neurologist. He's a little bit older than me, probably graduated in or around the same time, because he's been working in the health service for 20 years, same as me, and he says he's damn proud of it. Progress is painfully slow, but it is very real, and I think we have to hold on to this. Interestingly, he does a lot of work on patient safety, and he has felt that this renewed focus on patient safety, as Kathy mentioned, has improved teamwork, has improved patient-centeredness, has improved patient safety, and provided opportunities for mitigating risk and error. It's allowed us to look at integrating care. So you don't just look at the black and white thing of you've got epilepsy, therefore you go to a neurologist. Looking at integrating care between primary and secondary care, perhaps between regional care and centralised care, and constantly implementing new care models and new technologies. And it's really important, this is very clear in lots of the work that I do within the sexual assault treatment unit, within people with addiction issues, people with infectious diseases. The undeserved, the poor and the nameless are very often disproportionately affected by poorly performing services, and their health needs are higher, and it is important for us to speak up for those who may not be able to speak up for themselves, or indeed give people a voice who may be challenged by actually finding that voice for themselves. So in terms of our future, certainly our trainees represent the future of our specialty, and I know the training programme is hard, and I feel very responsible as one of the specialty directors when I say to somebody that for their training I think they should go to Cork, when I know their boyfriend's in Dublin or their family's in Dublin or the kids have to move school, and it's a huge responsibility, but it's also really important that we train people properly and that we don't just give them a soft life and have them not well trained at the end of it. People's opinions count. Everybody's opinion counts, whether they're a service user or whether they're a provider of healthcare. And it's important that we acknowledge the new paradigm within which we deliver care, take the good from it and run with it. And without a doubt, our patients deserve an always improving high quality healthcare system. But we have to deliver that with an appropriately resourced staffing complement, and we need to be irrepressibly ambitious for our future. We don't need to be forced into producing new services in a cost-neutral context. We need to advocate on behalf of our patients for the resources that we need to roll out new services and to continue to roll out high-quality healthcare. I do feel it's important that we realise that social media isn't the enemy, and we need to use our full range of communication techniques, whether they're conventional media, social media, and all the various other channels of communication that we have to drive development, integration and change. And although the future may be different, I think we need to embrace the opportunities and take the good and be ambitious about that. So I'm going to hand over to Sorka, who'll tell you what it's really like to be a trainee.